Perilunate dislocation. So we'll talk a few things about this thing. Perilunate injuries affect ligaments and bones around the lunate. So it is perilunate. And rarely it affects the lunate. So it's around the lunate injuries of the ligament and bone, put very simply. And what is a constant feature of perilunate dislocation? The dislocation of the capitate head from the concavity of the distal lunate. So lunate, this is normal, this is radius, this is lunate, and this is capitate. And lunate not getting fractured, the capitate may displace almost 97% of time dorsally, or capitate may displace volarward. So if it is displaced dorsally almost 97% of time, that means if you make a cut dorsally, the first structure you will see is the head of the capitate. The first shining structure that you see is the capitate, and that will be the guidance, that will be a beacon light for doing the rest of your surgery. It's a high energy trauma. That means the patient will be falling from a height or from a high speed motorcycle. And what happens, the hand goes into hyperextension and the lunate pops out. Now, there is a predictable progression of the injury following a fall, and this predictable progression starts from the radial side, which basically means the injury is first between the scaphoid and the lunate. So this ligament ruptures on the radial side. As the disease progresses from scapholunate joint, then there is a disruption between the capitate and lunate. So it starts from here, goes on the distal aspect of the lunate, and from here it progresses to the joint between the lunate and the triquetrum. So it's a progressive and always a set pattern. It always happens this way, either through the ligaments or through the bones in the adjacent area. And finally, the lunate pops out. The injury can be purely ligamentous, or it can be through the bone. Purely ligament through the blue line, or purely bony through the red line. When it is through the ligaments, it's called a lesser carc injury. When it is through the bone, it's called a greater carc injury. So it can be through the ligament or through the bones. Obviously, any injured part is going to be swollen, it will be deformed, it will be painful, it will have a range of motion which is reduced. Now, since it's a high energy, high velocity injury, look for injuries elsewhere. And the commonest injury that you are going to miss is not being able to lift the shoulder up because of a brachial plexus injury. And therefore, the simplest examination of brachial plexus, I'll try to make it simpler, is just ask the patient, lift up the hand. If they can lift up, in spite of all this injury, and presuming they don't have a fracture of the humerus radius ulna, this is a simple test. Also look for median nerve injury, vascular and open wounds, and of course airway, breathing, circulation. You need just X-rays, PA and lateral. And on these views you will not see the scaphoid, therefore you need a scaphoid view also. And try to cajole the patient and see if they can do it, because it's a painful test. You don't really require any more investigations in these patients majority of time, of course, except in chronic situations. And you will see what are called as Gilula's line. And if you draw a line on the proximal carpal row, distal edge of the proximal carpal row, and the proximal edge of the distal carpal row, they are not only parallel but they are congruent lines. And if this congruity is lost, that means something is wrong. And what is something is wrong? You see, this is right, but this doesn't seem to be okay, but it is still in continuity. But what about here? It is totally broken. So there is a perilunate injury, and these are almost normal. It is broken, but this in place. What about here? The bones are overlapping. They seem to be crowded. This seems to be definitely crowded. So what is normal? This becomes crowded. What you see here in the lunate, it is overlapping the scaphoid and the adjacent triquetrum. Now what you see, a scaphoid is long. Here the scaphoid is not long, it is looking only the tip, and it has become rounded. This is ring sign. Next you see here, the lunate has become triangular in shape because it is not lying like this. You are seeing this edge and this edge, two edges, and therefore it has become triangular in shape. This is in American books, there is a piece of pie sign. What is the management principle? If it is ligament injury, repair the ligament. If greater carc bone injury, repair the bones. Protect the nerve. Treatment, there is no role of conservative management, because even in the day 1, day 2, day 3, day 5, the bones have been able to be reduced close, it is going to fall apart, and therefore treatment is almost always surgical. Multiple papers have suggested do an open surgery. The goal of surgery is approximate bones and keep them remaining approximated so that ligaments fall in place and they heal just by being in contact. Approach can be dorsal, it can be volar, or it can be combined. Dorsal, you can put a screw or K-wire, or you have to often combine both volar and dorsal. So this is a dorsal approach, and what you see here is the first structure I said 97% situation capitated dorsal. So first structure you will see is the capitate. Volar side, this first structure you will see is the median nerve, and you see the median nerve popping here. So keep it back into alignment. Conservative, poor results. Majority of time it dislocates. What is important is accurate reduction. Example, so we had this patient, you have this spilled cup sign and lunate is lying outside. You put multiple K-wires. What is the idea? The ligament which is broken between the scaphoid and lunate, you keep it for about 8 to 10 weeks, so ligament hopefully should join. The ligament between these hopefully should join, and ligament hopefully. So put multiple K-wires so that they remain in place and ligaments heal. Another patient, with this patient I just talked to you, and this has been relocated. Another patient, fractures the scaphoid, crowded carpal sign, put them. Now often that once you take the patient, because there is no ligamental support on the lunate, it tends to fall. You can't hold it, it's too difficult, and therefore temporarily put a K-wire from the radius to lunate so it remains in place, and then do rest of your fixation and then withdraw this wire. So temporary stabilization of lunate helps. What is late? Books have said even as late as 35 weeks the reports have been good. So what you can do is, if you have one of these patients, distract it. Once you distract it, you start seeing the bones which are now not overlapping, and now you do, after distraction, you do the correction and it becomes easy. The article says proximal row carpectomy leads to results as good as those with open reduction. So even proximal row carpectomy has been suggested. How not to do is also important. What you see here is a fracture of the styloid process of the radius, but what about this bone? This is lunate. This is lunate, and therefore putting the K-wire in the styloid process, because we understand radius well, we don't understand res, is not a good idea, and therefore this is a missed perilunate dislocation. So summary, the lines of the carpal rays have to be maintained, protect the median nerve and put them in alignment, and you will be safe. It's a big spectrum of injury. There might be injuries other places also, because a high velocity injury lead to this, but always they require open reduction, K-wires, screws. There are times when patient presents late, either you distract them and put them into alignment. If this is not possible, and if you notice it, the cartilage is damaged, do a proximal row carpectomy.